Okay, can everybody see the slide?
Yes po, Doc.
Yes po, Doc.
Yes po.
Sige.
Good morning po, Doc. Can we start na po?
Yeah, we can start now.
So, good morning, everyone. We are group B6 and we will be presenting case 5. Okay, next slide po. So this will be the outline of our presentation. So we'll be first presenting the case of the patient, which is composed of the subjective data, history of present illness, past medical history and medication, social history and family history, review of systems, objective data, and laboratory tests, followed by the localization, then the primary impression, differential diagnosis, diagnostic workup, management, and prognosis. Next slide. So now we would be first going on with the case presentation of for the identifying data of the patient. So patient is a 60-year-old female, right-handed, Filipino married, Roman Catholic, housewife from Pasig City, Metro Manila, and was brought to the emergency room due to decreased sensorium. So yung chief complaint niya po ay decreased sensorium. Okay, next slide. For the HPI, 1 month prior to admission, the patient started to experience intermittent episodes of dyspnea and bipedal edema. Dyspnea was exertional and was also noted upon lying down. And then it was relieved by rest by using 3 pillows to prop her head at night. And she also complained of decreased volume of urine output with darker yellow color but denied dysuria. And during this time, no consultation was sought. Then, symptoms persisted until 1 week prior to admission. Then, previous symptoms recurred, but now with ascending bipedal edema and postprandial vomiting. So, during this time, wala pa rin pong consultation na ginawa. Next slide. As the case progressed, no, 1 day prior to admission, further progression of edema of the lower extremities was noted, and meron pa rin dyspnea while sitting down naman, no, and felt like she always needed to catch her breath. So in Tagalog parang hinahapo siya, no. And then these symptoms prompted consult at a local hospital. Then patient was advised hemodialysis, but due to lack of facilities sa pinuntahan nila, the patient was transferred to this institution. And then upon arrival at the emergency room, the patient was difficult to arouse, hence was referred to our department for evaluation. So for the pertinent positives and negatives of the patient, for the pertinent positives muna, the patient positive for orthopnea, decrease in urine output or oliguria, and then easy fatigability. For the pertinent negatives, we have fever, negative for fever, loss of consciousness, slurring of speech, blurring of vision, diplopia, weakness, and numbness. And then for the next slide po tayo, for the review of systems. Ayan. For the review of systems, sa skin, no, positive siya for dry skin, no rashes or lesions naman. Then for eyes, no excessive tearing or pain. For ears, no discharge, gross lesions, and intact yung tympanic membrane niya. For nose, throat, and mouth, no changes in olfaction, no nasal discharge, epistaxis, and odynophagia. And then, for respiratory or odynophagia or pain swallowing. For respiratory, no wheezing, cough, and colds. Cardiovascular, no syncope and chest pain. For GAT, no abdominal pain, melena, indigestion, heartburn, hematemesis, fatty food intolerance, hemorrhoids, abdominal distension or hernia. For urinary, no dysuria, color change, or nocturia. For extremities and musculoskeletal system, no cyanosis, clubbing, varicosity, and ulcers, but she has multiple hyperpigmented areas of the bilateral leg or the lower extremities. Then for hematopoietic, no excessive bleeding or bruising. For the nervous system, no fainting spells, seizures, or tremors. Next slide.
So for the past medical history, the patient has diabetes and hypertension for 10 years, both poorly compliant, and there is no asthma, allergies, or cerebrovascular disease. So for the family history, there is a history of hypertension in the maternal grandfather. Family history is unremarkable for bronchial asthma, cardiovascular disease, cerebrovascular disease, thyroid disease, diabetes, and allergies. So for the personal and social history, the patient is a housewife, non-smoker, non-alcoholic beverage drinker with no history of illicit drug use. Next slide, please. So for the physical examination, upon admission, the patient was noted to be eyes closed, no verbal output with spontaneous purposeful movement. of all extremities with vital signs are stable except for tachypnea at 28 cycles per minute. HEENT shows pale palpebral conjunctiva and oral mucosa. Lungs have bibasal crackles. Extremities with grade 3 bipedal edema with pulses full and equal. So cardiac and abdominal exams were unremarkable. Next slide, please. For the neurological exam, on mental status exam, the patient is stuporous with no eye opening or verbal output, but has spontaneous purposeful movements of all extremities and localizes to pain. She does not follow commands. For the cranial nerves, pupils are equal with 2 to 3 millimeters, briskly reactive to light, with intact direct and consensual reflexes. Fundoscopy showed distinct these borders with no papilledema, esotropia noted on the left, but extraocular movement intact on Dell's eyes. Corneal reflexes are brisk bilaterally and no facial asymmetry elicited. Next slide, please. So for the motor exam, there's normal tone, no atrophy, and with strength of 3 out of 5 in all extremities. So this motor exam shows purposeful movement of all extremities in response to pain, since true strength cannot be fully assessed due to stupor. So for the sensory, the patient localizes to pain in both upper extremities and grimaces to pain in both lower extremities. So for the reflexes, biceps, triceps, and brachioradialis are normal bilaterally. Patellar reflex is hypoactive bilaterally, and Achilles reflex is absent bilaterally, and no pathologic reflexes elicited. So there's also no meningeal signs, and cerebral testing cannot be assessed. Next slide, please.
Now
Okay,
for the
before we go to the
sorry.
laboratory, Patlin, okay,
Yes, Buddha.
you've seen my lecture,
Yes, Buddha.
you've read my lecture.
Yes, Buddha.
Okay, what do you think are missing in the PE and focus neuro exam? Okay, go back to the slide of your PE. So anyone in the group or anyone from your classmates can volunteer. So look at the PE. Are we missing something here? Anyone? Any important uh, any important data which should have been placed here or given in the protocol? Kita mo yung table na binigay ko sa inyo, yung clinical pearls in the physical exam. And anyone from the group?
Hello, Doc.
Yes, yes.
Doc, from the general appearance po, it was mentioned naman na the eyes were closed, no verbal output, and then the movements of the extremities were also mentioned. However, it would be nice if it was specifically mentioned that the Glasgow use the results of the Glasgow Coma scale.
So that will be in your focus neuro exam.
Yes, Doc.
Okay, what about here in the PE? What is missing?
Can I try po?
Yes.
Siguro, pwede rin pong ma-add since based sa history po ni patient, later on will be discussed na she is diabetic as well and hypertensive. So siguro po it would be important to note as well na sana na-perform din yung fundoscopy wherein para makita po yung details nung yung mas ma-further discuss or ma-elaborate kung ano yung nakikita din sa loob ng eyes ni patient since it is helpful as well for diabetic and hypertensive patients to note or to include in the examination.
Yan, that should be placed in the neuro exam. Your fundoscopy is in the neurologic exam. What about here in the PE? What are we missing? This patient has been having shortness of breath, has been having orthopnea, okay, dyspnea. So what is missing in the head and neck examination?
No, is it related to jugular venous distension po? If there is possible congestion na po if yung
Yes,
sa JVP po if
very
yun po
good.
if
Very good. So we want to know the status of the jugular venous pulsation because distended JVP will give us a clinical clue that this patient is in failure. Okay? What about the other components which I gave in the lecture and not here? The breath, di ba? The breath will be very informative because you have in mind what's going on in this patient. So he was, she was advised hemodialysis, so maybe the problem is related to kidney. So what do you want to look for the breath?
Doc,
Pat,
if based from my ay sige po Doc.
can we
Go po.
ask Kathleen?
Doc, yung breath po kasi would tell us if there is metabolic encephalopathy po.
Nga. So dito, in-advise siya ng hemodialysis. So there is a clue that this might be uremic. So what do you expect from the breath? Ala, hindi yata nagbasa ng aking lecture. Na-upload yun, di ba, ni Dr. Castillo? So ano breath ng isang may renal failure?
Doc, may ammonia odor po.
Ammonia ba? Di ba sa DKA, Angela? Pag nag-exam pala tayo ngayon, A, B, C, D, mali tayo. Ammonia is DKA. In renal failure, what is it?
Doc, uriniferous odor po. Parang smell ng
Correct. Correct. Alam nyo ang ano nun? Alam nyo ang ibig sabihin nun? Mapanghi. Mapanghi yung breath niya, just like a urine. Okay? Which is missing here. So kaya ko tinatanong kayo, what should have been placed in the protocol which are vital but not given. Okay? So we've identified JVP. Another one is the breath. Okay? Are we okay with the heart examination? Kompleto? What is missing?
Doc, yung peripheral pulses po daw.
Yes, we are. That will be under the pulses, Nicole. Sa chest and lungs. Sa heart. Ano yung, what is missing here? Which will give you a clue that there might be left ventricular hypertrophy. Remember, uncontrolled hypertension yan.
Ito, pwede yung apex beat position po.
Again.
Yung position po ng apex beat.
Okay, which is your point of maximal impulse. Okay, that is your PMI, which was not given here. Okay, sa chest and lungs, you were given equal chest expansion by basal crackles, no retractions. What is missing? Diba dapat kompleto ang PE natin? So what's missing here?
Doc, try lang po. Baka po pwede yung mga tactile fremitus.
Very good.
And
Your tactile and your vocal fremiti. Kasi may crackles ka eh. So we wanted to know the status of those crackles. Okay? So I think that will be all, or can you still see some data that should have been given before we go to the neuro exam? Pero look here, yung general appearance has spontaneous, purposeful movement. Okay? Remember that. So we go now, let's move now, Pat, you move the slide now to your neuro exam. Okay, so any comment in your neuro exam? Kasi dito, ang general mo is 2 porous na, which is not compatible with the general in the PE. Sa PE, mas spontaneous siya eh. But here, your patient is 2 porous, no eye opening to sternal rub, no verbal output, but spontaneously moving all extremities. So in my lecture, compatible ba yung spontaneously moving at saka stuporous? Diba? If your patient is in stupor, you will have to need deeper painful stimulation to elicit response. So dapat siguro, ang correct data dito is not spontaneous. Because if you say spontaneous, even without any stimulation, the patient will move all extremities. Diba? Hindi ba kayo nalito doon sa data? Okay, but that's how the protocol was presented. That is why we will have to critique it. Okay? Okay, sige. Anything else in your... nandito naman dyan yung iyong fundoscopy. Okay? So seems there is no sign for diabetic or hypertensive retinopathy, which I also doubt because this patient is non-compliant to medications and the diabetes and hypertension are uncontrolled, diba? So I doubt that this fundoscopic examination is normal. Okay? Anything else? Can we move to the next slide of neuro exam? Yun muna. Ayan, okay. So I see, yung sensory mo localizes to pain. So ano ba talaga? Spontaneously moving or you have to induce pain? Okay? Okay, so before going to your laboratory, I want you to localize first the problem.
Also for the localization, next step. So, this is a diffuse cerebral dysfunction secondary to metabolic encephalopathy, specifically uremic encephalopathy complicated by severe hyperkalemia and metabolic acidosis.
Okay,
Clinical
Kate, before you proceed, when we say localization, He will not give the etiology. He will tell us where the lesion is. So what part of the neuraxis, what part of the brain or the spinal cord is involved?
The cerebral cortex.
Again,
Cerebral cortex.
cortex. Okay, very good, cortex. Why cortex?
Um, Kasi po, first po, the patient presents with weakness sa both upper and lower extremities. And the results of neurologic examination showed po na may yung motor strength of 3 out of 5 sa both right and left and lower and upper extremities of the patient, in which both sides are equally affected. And the sensory examination shows
Can
that
I not localize it somewhere else? Like, for example, I'm going to involve the medullary pyramid. Won't I get the same motor strength? My question is, why are you involving the corticospinal tracts at the level of the cortex, not at the basal ganglia, not at the midbrain, not at the pons, not at the medullary pyramid? Do you have the
kasi
do you
po,
have the slide of the ARAS?
there's no slide for the RAS po, Doc. But intact po kasi yung brainstem pathways and
Very
reticular
good. Very good.
system.
Okay. So you will attack the problem depending on the main complaint, which is your decreased sensorium, di ba? So very good, Kate. So if there is decreased sensorium, you are involving the ARAS.
Yes.
And we know that the ARAS is from the diencephalon, midbrain, and upper pons, and then from there will project to the whole cortex. Okay, so at what level are we affecting the ARAS? Cortex pa yan or brainstem? And you are correct. Since the patient has no brainstem manifestations, that is why you are localizing it cortex. So you are affecting the ARAS at the level of the cortex. Okay, so ganun muna, localization. Di ko muna maglalagay dito ng mga etiology. Ha? Ang etiology ilalagay nyo sa where is the lesion. Ngayon, nasa ano kayo? What is the lesion? I'm sorry, where is the lesion? Ang susunod nating, the next thing we will tackle is what is the lesion. Doon mo ilalagay yung diffuse cerebral dysfunction. Okay? Sige, proceed.
And Doc, to add lang po, kaya po na-conclude na yung brainstem pathways and yung REAS remain intact because there are no cranial nerve pulses present. So it showed that the pupils are equal. So 2 to 3 millimeters and briskly reactive to light with intact direct and indirect pupillary light reflexes. Bilateral corneal reflexes are also present and there's also intact oculocephalic reflex and no facial asymmetry noted. So for the next slide.
Okay, so for this slide po, we're just going to be providing additional reasons po why doon yung na-pinpoint namin na lesion. So for the mental status findings, our patient kasi is stuporous with no verbal output but meron siyang spontaneous purposeful movement. So this tells us that the cortex is impaired while subcortical circuits remain functional. So according to the mayor, when you see absent verbal output with preserved brainstem reflexes, you're looking at diffuse hemispheric dysfunction, not a focal brainstem pathology. Also, speaking of brainstem reflexes, sa patient natin, they are all intact, equal reactive pupils, bilateral corneal reflexes, intact dog's eye maneuver, no facial asymmetry. So this preservation pattern is pathognomic for metabolic encephalopathy. So yung brainstem kasi, resistant siya to metabolic toxins while yung cortex natin is vulnerable. Yung laboratory, mamaya makikita natin, the laboratory values support diffuse dysfunction through 3 mechanisms. So first, yung severe uremic toxicity, yung creatinine kasi.
Ay, Colleen.
Yes
So,
po.
i-move mo na dapat itong severe uremic toxicity, severe hyper-K, severe met acid sa next slide ng what is the lesion. Okay? So, ang general heading natin is what is the etiology? So, you will say metabolic encephalopathy. Most probably, number 1, uremic enceph. Okay?
Okay po, Doc.
Ganon kayo mag-iisip sa neurology. And then give 2 differential diagnosis. So your differential will be severe metabolic acidosis. I will not agree to hyper-K because this will not affect the level of sensorium. Maybe sodium, yes. Okay? Sige.
Mag-next slide na po, Doc. Or tuloy ko po yung
Yes,
next slide.
let's go to your next slide.
Okay po. Thank you, Doc.
Add lang sa normal physiology ng brain, yung consciousness and wakefulness is mainly maintained by the ascending reticular activating system and the cerebral cortex. So the iris receives the sensory input and then sends the signal to the cerebral hemispheres. So kapag yung it's either yung brainstem or yung cerebral cortex na damage, magkakaroon ng impaired consciousness yung patient.
So for the normal cerebral cortex function, we have sa yung cerebral cortex po kasi siya po yung responsible for for receiving, sending, processing, and interpreting po the information, di ba, received from the body. So kailangan po siya to maintain sensory and motor function. So if unaffected siya nung diffuse cerebral dysfunction po, the motor areas of the brain which are most likely affected in the patient would otherwise be unaffected. So what does this mean po? So makikita po dapat kasi yung sa neuro exam po. So patient po kasi is with distal extremities po, po siya 3 out of 5 motor, which we'll discuss later po on. Pero since we're in the localization na, so we can say that the primary motor cortex or your Brodmann area 4 is affected, which is responsible for your voluntary movement. Kasi on the contralateral side, it includes the corticospinal tract, which is also associated with the somatosensory cortex. So yung po kasi is we can see in the image, the corticospinal tract, it travels through the internal capsule. We can see po there, di ba, yung parang po siya, nag-gather po yung yung bundle, nagta-travel siya doon, and then they will go to the cerebral peduncles as they go down the medulla. So 75 to 90% po nung corticospinal tract will decussate po on the contralateral side. And your contralateral side decussation, this is responsible for your movement of your extremities. And yung nakikita po natin yung anterior corticospinal tract in the image, in the medial side, yan po yung responsible for your axial movement. So yan yung trunk and yung shoulders mostly. So voluntary movement in the distal extremities is affected in the patient, which may suggest that the anterior cortical spinal tract may have been spared as it is responsible for axial movement. Add na lang din po natin dito yung corticobulbar tract, which is also part of your head and neck movement, since wala naman po sinabing may problem po si patient there. And so in a normal setting, the patient would have no problem with equal voluntary movement for both axial and appendicular areas of the body on both sides if normal. And we can see po later if we discuss po the neurological exam yung motor function po ng extremities ng patient, both po is affected, and we will see that po later on.
Okay, next slide po tayo. Proceeding to the primary impression. So our primary impression, in conjunction with what was discussed earlier, is uremic encephalopathy secondary to end-stage renal disease. So ano ba tong problem na to, no? So this is a cerebral dysfunction which results from toxic accumulation caused by acute or chronic renal failure. Pero in our patient nga, no, madidiscuss later on based sa laboratory values niya kung ano ba yung parang pinaka-specific na nangyari talaga sa kidney niya. Especially when the patient's GFR falls below 15 milliliters per minute. So the pathophysiologic event usually progresses from altered hormonal metabolism, uremic solute retention, aberrant electrolyte and acid-base homeostasis, impaired blood-brain barrier transport, and inflammation na later on ma-elaborate pa po natin sa pathogenesis on what happened to our patient. Sige, next slide.
I think bago tayo mag-proceed, dun muna tayo sa lab results, no? Para mas maano yung...
Yeah, before we proceed, can I ask Jan?
Yes po.
So what's responsible for the decreased level of sensorium here in uremic encephal?
Siguro po, Doc, is it okay to discuss the pathophysiology na rin po to relate what happened as well to the patient or kung paano po nag-progress to the
Are you
decreased
going to
sensory?
discuss this later in the
Yes po. Yes po, Lord.
sige.
Doc, may diagram po kami later kung
Okay.
paano po nag
Sige. Let's proceed.
So, sa lab po muna tayo, no? So, wait. Yeah. Yan.
So for the laboratory test po, so under the electrolytes, yung potassium po, it shows severe hyperkalemia due to its higher than normal range, and this indicates an increased risk of heart arrhythmias. As for the others, calcium and magnesium were both reduced, while phosphorus is elevated, and all of the aforementioned strongly suggest kidney impairment as kidneys are failing to excrete potassium and phosphate, and in terms of magnesium, its deficiency could worsen hypocalcemia and arrhythmias. For the renal function, so yung creatinine and yung BUN, both are increased. For creatinine, it's extremely elevated with the estimated eGFR as 2 milliliter per minute per 1.73 liter squared, and this is categorized as stage 5 CKD, and this suggests severe renal impairment or end-stage renal disease. And since BUN and creatinine are elevated, this confirms azotemia from kidney dysfunction. For liver function and enzymes, only the albumin showed abnormal results, which is lower than the normal range, suggesting malnutrition or chronic illness. Next slide, please. Under the hematologic category, it shows low hemoglobin and hematocrit, and this suggests severe anemia, high WBC, indicating mild leukocytosis, while the increased segmenters and decreased lymphocytes suggest stress or an inflammatory response. For the coagulation, the prothrombin time and INR are slightly elevated, and this suggests mild coagulopathy. In terms of the cardiac enzymes, creatinine kinase CKMB is increased. This suggests that there is a distress in the cardiac muscle, since CKMB is an enzyme is an enzyme and a cardiac marker that is released in the bloodstream in times of damaged cardiac muscles or distress. And since troponin I is negative, this could indicate the absence of myocardial infarction. Next slide, please. For the imaging, chest X-ray shows cardiomegaly with pulmonary congestion, and this could suggest the likelihood of heart failure, while ECG showing normal sinus rhythm and left ventricular hypertrophy shows chronic hypertension effect on the heart. Now, lastly, for the arterial.
That Nicole, meron siyang LVH by ECG and cardiomeg by X-ray. That's why we're asking for the PMI, di ba? Which is very important in your PE. Sige, proceed.
Okay. So for arterial blood gas naman po, so lahat po normal po since yung pH level po it's reduced this indicates acidosis and mataas yung partial carbon dioxide and mababa yung bicarbonate. So this could suggest or this shows mixed metabolic and respiratory acidosis. And yung partial oxygen and oxygen saturation are decreased, and this could indicate mild hypoxemia and low oxygen saturation. So, yung metabolic acidosis, this could kasi since meron siyang acidosis and meron siyang metabolic, it suggests na meron pong yung patient na metabolic acidosis, and since meron din siyang respiratory acidosis, this suggests that yung respiratory compensation, it's not reflected and hindi nagko-compensate adequately yung lungs due to respiratory problem.
Ba siyang respi-alka? Your PCO2 is
Respiratory acidosis.
Your PCO2 is high, which means your CO2 is low. Diba?
Sorry po.
Your PCO2 is high. The normal value is 35 to 40, diba?
Yes po.
So if your PCO2 is high, that means your CO2 is low. Okay? So alkalotic siya.
Okay.
Okay,
So
look
it's
at your
it's
carbon, look at your HCO3, which is very low. So that is acidotic. Okay?
Yes.
So this is metabolic acidosis, and your respiratory system is trying to compensate. Okay? Ganun yun. And then you have hypoxemia. Okay.
Noted po, Doc. Thank you.
Yeah, let's move on dun sa previous part. Yan. So, ayun na yung primary impression natin is uremic encephalopathy secondary to end-stage renal kidney disease. So, ito yung etiology natin.
So before we move on to the pathophysiology of uremic encephalopathy, let us first discuss its etiology. So uremic encephalopathy is caused by the buildup of toxins in the blood due to poor kidney function. The onset and severity of the encephalopathy generally parallels the severity of azotemia. So while an eGFR of 15 milliliters per minute already manifests with severe cognitive changes, studies show that moderate signs and symptoms can already be identified at the eGFR levels between 40 to 60 milliliters per minute, such as mild memory lapses, reduced attention span, and mental fatigue. In addition, the toxin buildup can cause inflammation to the blood-brain barrier, further increasing its permeability, allowing more toxins to cross into the brain. And kidney dysfunction and or failure impairs the kidney's role in excreting excess electrolytes and the reabsorption of bicarbonate to maintain the pH level, and the osmolality of the plasma is also impaired. Thus, it leads to electrolyte imbalance and, like what Nicole previously mentioned, metabolic acidosis, which in turn can decrease the pH level of the CNS, affecting neuronal excitability, leading to altered mental status, lethargy, and respiratory compensation. So this condition is generally reversible with dialysis, with an identified lag time of about 1 to 2 days before mental status comes back normal. However, some subtle cognitive difficulties may persist even after dialysis in patients with chronic renal failure. And in cases that there is failure to improve following dialysis, the physicians should start to consider other possible etiologies of encephalopathy already. So risk factors to developing
Shirley,
yes,
and Leah, do you develop cerebral edema in uremic enceph?
I'm sorry, Doc, ano po?
Do you get cerebral edema in uremic encephalopathy to explain your decreased level of sensorium?
You could po, Doc, since the blood-brain barrier is inflamed, it's more permeable.
Okay, surprisingly, if you read Adams, so you consult Adams uremic encephalopathy, usually, okay, or in general, they will not develop cerebral edema. Okay, that is the beauty of uremic and sep. And the reason for decreased level of sensorium is secondary to the other factors. Like in this particular patient, she has severe metabolic acidosis, so that can be one. Okay? Pero we will agree na your high creatinine can give you severe cognitive changes and like in patients with dementia. So progressive yon. But uremic NSEP per se, giving rise to decreased sensorium, cannot be explained by cerebral edema. It doesn't really happen in uremic NSEP. In hepatic NSEP, yes. Okay? Sige.
Okay po. So, risk factors to developing uremic encephalopathy include diabetes, hypertension, heart disease, obesity, and a family history of kidney disease. Both diabetes and hypertension was mentioned na meron si patient, both poorly controlled since she is not compliant to medication as well. So, for the pathophysiology, we have John.
Yeah, wait, sige. So, first, let's discuss muna yung sa pathophysiology. So, and we'll also try to make sense kung bakit ganun yung nangyayaring symptoms. So bakit nagkakaroon ng edema, bakit tayo nagkakaroon ng dyspnea. So, ayun. So, ayun nga sabi, we have uremic encephalopathy due to kidney failure. So, it all starts sa decline sa kidney function due to yung uncontrolled diabetes at hypertension. So, first, no, hypertension could lead to hyaline arteriosclerosis, so wherein the arteriolar walls will thicken and the lumen will decrease. So, ang nangyari dito is we have reduced blood flow sa kidneys. So, nakakaroon ng ischemia, and syempre, we expect na magkakaroon ng decline in kidney function. And for diabetes naman, this can lead to glycosylation of yung basement membrane. So, ang nangyayari dito is kumakapal yung basement membrane and nawawala yung selectivity niya. So, everything starts sa hypertension natin and sa diabetes. So, now, let's proceed muna to explain kung bakit tayo nagkakaroon ng bipedal edema. So again, all starts sa impaired kidney function, no? So right here, yung sa picture sa right, we have yung, we calculated yung eGFR from our serum creatinine. So this is just based from MD Calc. So this is a practice na tinuro sa amin ng med precept namin. So kasi it helps us to give a better idea kung ano nangyari sa kidney. And siguro mas important note din is it also helps us with management, no? Kasi if you know your kidneys are bad na, then it's always a question of can the drugs that I'm gonna give to my patient, can the patient kidneys handle them? Okay? So siguro if we have a stage 5 CKD, maybe we can lower yung dose para less yung affectation sa kidney, or maybe we can find drugs that can affect the kidneys less. Okay? So we already established kanina, we have impaired kidney function. We can have mataas yung potassium natin, mataas yung iba't ibang levels. So, ba't tayo nagkakaroon ng edema? We saw kanina we have a normal sodium levels, that's 138 millimoles per liter, and yung normal natin is 135 to 145. So bakit normal yung sodium levels tapos yung ibang electrolytes natin mataas? So this can be attributed to dilution, no? Since wherever sodium goes, water follows. So possibly, pwedeng initially mataas ang sodium, pero na-dilute siya ng water, kaya nagmumukha siyang normal. So this is one of the reasons kung ba't nagkakaroon tayo ng edema. And of course, we also have a hypoalbuminemia. So this is about syempre, by yung sa diabetes natin, mas less selective yung basement membrane and filtering, so mas naiihi lang natin yung albumin. So if there's a decrease in albumin in our blood, nag-decrease yung oncotic pressure or yung inward force ng fluids towards the blood vessels. So nagkakaroon din tayo ng edema. So that explains this symptom.
Raf, what's the danger of hyperkalemia?
Hyperkalemia po,
Big
Complication.
Nagkakaroon po ng cardiac arrhythmia po.
Very good. So that's the fatal complication of severe hyperkalemia, okay? Malignant arrhythmia, and that can be very fatal to the patient. Okay, sige, proceed.
So for our next symptom after bipedal edema, pinaka na-notice natin would be yung dyspnea. And this is brought about yung ating pulmonary edema. So we mentioned kanina that meron kang left ventricular hypertrophy. So ba't ka ba nagkakaroon? So this is because of hypertension. So again, everything leads back to yung hypertension and diabetes mo. So what happens is that kapag hypertension, tumataas yung systemic or rather tumataas yung afterload. So when we say afterload, yun yung the amount of work that the heart has to overcome to pump blood. Hello?
Ayan, yeah, we can hear you now.
Okay. Doc, naka-share pa po ba yung screen or hindi?
Ngayon, hindi.
Okay po.
Nag-post ka kanina, tapos nawala.
Okay po. Sorry. Okay. Ayan. Kita na po ba?
Yes, okay na.
Okay. So, not sure where I last left off, no? Pero we mentioned na meron ang increase in afterload, kaya tayo nagkakaroon ng hypertrophic left ventricle. So, remember that the left ventricle is connected to your left atrium, and left atrium is connected to your pulmonary circulation. So, pressure will tend to equalize or normalize. Kaya yung pressure from the left ventricle, pupunta yan sa left atrium. Pag tumaas yung pressure sa left atrium, tataas yung pressure sa pulmonary circulation. So this is why nagkakaroon tayo ng pulmonary edema. So kaya tayo nagkaka-dyspnea rin. Okay? So after that, we also explain kung bakit tayo nagkaka-altered sensorium. So I think si John not here.
Yes po. Ayan. So, going back to Doc's question earlier po, no? So this would be the parang pathogenic mechanism as to why the patient...
Sorry, Rafael.
Yes po.
Bakit siya walang chest pain? Wala, no? This patient...
Wala nga po,
Oo,
Doc.
bakit? Bakit kaya? Di ba meron siyang LVH,
Yes po, Doc.
siyang overload, and yet, why is she not manifesting with chest pain?
Doc, possible po ba dahil walang ischemia na
Sometimes wala kang ischemia, but you can still have chest pains, especially with those overload signs and symptoms. Bakit kaya? Anyone from the group? Or anyone from your classmates?
Is it, ano po ba, if I can guess lang po, is it adequate compensation po because unaffected po yung brainstem? Or
Adequate compensation. Halimbawa, nasa stage pa siya ng inadequate compensation. Bakit walang chest pain? Look at the other risk factors she has. Uncontrolled. Yan, tingnan nyo yung number 1.
Diabetes?
Yes.
Uh,
Uh, so how can uncontrolled diabetes bring about absence of chest pain?
Doc, possibly po like neuropathy, like nananumb po yung
Very good.
pain sensors
Very
po.
good. So, meron na silang neuropathy, not only neuropathy to the extremities, but also neuropathy to the truncal muscles. So your patient, a lot of your a lot of your diabetic patients usually will not manifest with chest pain, but anginal equivalents. Okay? Yun ang reason. Okay, sige, proceed.
Ayan po. Going back to the presentation po, or the pathophysiologic mechanism. So, na-discuss kanina ni Rafi yung pinaka parang complaint, I mean additional complaints niya no, ba't nagkakaroon ng bipedal edema and ba't nagkakaroon as well ng parang difficulty of breathing. No? So, ngayon, we will be discussing how the patient progressed to having the decreased sensorium. So, we will be starting first from the patient's past medical history. Mentioned earlier na she's uncompliant with the medications for diabetes and hypertension. So it probably or it possibly led to the patient progressing to end-stage renal disease. No? So pag nagkaroon ng ganito, ng ESRD, it causes the patient's nephrons to deteriorate, thus leading to accumulation of neurotoxins. No? Ito yung isa sa mga important na manote natin, yung accumulation of neurotoxins such as urea, indoxyl sulfate, guanidine compounds, indolic acid, phenols, and carnitine. So yung toxins na to, yung buildup ng toxins na to, it disrupts the neurotransmitter balance, no? Specifically, resulting in excessive NMDA or N-methyl D-aspartate receptor, which is a type of glutamate receptor. So yung excessive NMDA activity sa left part ng diagram natin, no? And impaired GABAergic transmission, which leads to cortical dysfunction. And then moreover, electrolyte and acid-base imbalance sa may right part naman ng diagram natin, no, yung arrow na yan, yung electrolyte imbalance as well, or acid-base aberrations happen specifically hyperkalemia, hypocalcemia, hyperphosphatemia, and severe metabolic acidosis, just like what was mentioned earlier by my group mates, no? So, ano naman yung nagiging effect nito sa patients current status, no? So, it impairs neuronal excitability and synaptic function. So, pag mababa yung calcium, for example, yun nga, hypocalcemic si patient and high phosphate levels, no, hyperphosphatemia, it exacerbates neuronal instability and may lead to seizures. However, hindi pa siya mentioned sa case na nag-seizure na si patient or yun nga, decreased level of consciousness. Dahil dito nga, no, less extracellular calcium usually competes with sodium at the voltage-gated sodium channels, which lowers the threshold for depolarization. Kaya yung neurons, nagfa-fire siya more rapidly and easily, no? And since phosphate excretion is impaired as well, nagbabind siya sa calcium which forms calcium phosphate complexes. And anong nang ginagawa nito, no? It further decreases free ionized calcium, hence na-aggravate yung hypocalcemic effects. Tapos, moreover, no, sa nagiging imbalance na to na nangyayari, it can also be related to oxidative stress and endothelial dysfunction in the central nervous system, no, further impeding cerebral metabolism since nagkakaroon na nga ng reactive oxygen species or ROS from mitochondrial dysfunction. Tapos, yung chronic uremia as well na from the patient, it impairs astrocyte function na makikita natin sa gitnang part ng diagram and blood-brain barrier homeostasis which results in swelling and disturbed glutamate handling. No? So, ano ba muna yung astrocytes? So, when we remember na yung astrocytes, they function for structural and metabolic support, also in neurotransmitter regulation and brain barrier maintenance. So if disrupted yan, so magkakaroon din ng problem with the blood-brain barrier. So yun nga, no, it manifests with cerebral, although yun nga, no, more on sa diffuse slowing of cortical activity, yung nagiging problem din dito na later on madidiscuss sa diagnostic test. So kasi manifest yung diffuse slowing of cortical activity. Usually makikita yan sa EEG, no? Reduction in speed and frequency of brainwave patterns in the cerebral cortex. Yun. And then excess glutamate in the extracellular compartment means excess NMDA receptor activation since it's a type of glutamate receptor nga, yung NMDA, on the neurons which result in sustained calcium influx, neuronal hyperexcitability, and excitotoxicity. And then, moreover, no, there are secondary systemic effects. Makikita natin dun sa may left side ng diagram, yung na nag-add no, sa current manifestations of the patient. So, first is anemia manifested by her hemoglobin level of 72 grams per liter. This reduces oxygen delivery to the brain, which further worsens cerebral hypoxia. Then another is volume overload na sa right side na na-discuss din kanina, no? Yung volume overload with pulmonary congestion dahil nga impaired yung sodium and water excretion because of her ESRD. No, so, yun nga, nabanggit din kanina, nagkaroon ng excessive preload, left ventricular hypertrophy, stiffened heart, and increased hydrostatic pressure to the pulmonary venous circulation as well, which contributed to the hypoxemia and carbon dioxide retention of the patient. So, the overall cascade result from the pathophysiologic events lead to diffuse symmetric impairment of consciousness from confusion to stupor. So the patient is stuporous, no, with preserved brainstem reflexes and no focal neurologic deficits. So overall, no, the altered sensorium of the patient reflects the cerebral dysfunction from toxic accumulation, like what I've mentioned earlier, electrolyte shifts, and acid-base imbalance, specifically metabolic acidosis and hypoxemia or anemia as well. Ayun. Next slide tayo.
And so for our GCS scale, so remember sa GCS natin, we have three components, no? Yung sa eye-opening, sa verbal response, and motor response. So for our eye-opening, so syempre was mentioned na no eye-opening to sternal rub. So syempre, matik na 1 na siya. So none. And then for verbal, no verbal output din sinabi despite sternal rub. So again, score 1. So yung nagkakalito tayo is yung sa motor, di ba? So as mentioned kanina, na-mention na spontaneous purposeful movement of all extremities, but again, it's not consistent with yung stuporous natin. So siguro mas accurate if you would just say localizes to pain. No? Kasi gumagalaw pa rin siya, and also at the same time does not follow commands. So definitely it's not a 6. So we would score it a 5. So in total natin, so 5 plus 2, that's 7. So this will fall under moderate brain injury natin. So that's 9 to 12 po.
Moderate or severe?
Oh wait, sorry, severe. Sorry, severe po, Doc. Yes,
3
severe,
to
severe.
8, yeah, 3 to
Yes
8.
po, sorry. Yeah.
Yes, 3 to 8 is severe.
Yes po. So severe po. Yes.
Okay, so for the differential diagnosis first is congestive heart failure with pulmonary edema. So, rule in po dito is yung dyspnea on exertion or topnia na nabanggit din kanina na the patient requires 3 pillows at night. So, on physical examination, there were bibasal crackles, cardiomegaly, and bipedal edema. And also on ECG, it showed left ventricular hypertrophy, which supports the long-standing hypertension and possible heart failure of the patient. So, our rule out factors include the patient had an oxygen saturation of 99% on arrival, which is not typical for severe hypoxemic pulmonary edema, and also the presence of metabolic derangements such as acidosis and uremia suggests that the altered mental status is not primarily due to heart failure. And yun nga po, wala din pong chest pain or ischemic symptoms na uh, na na record kay patient. And also next
When you
is
are ano,
diabetic nephropathy po, ayun, poorly controlled diabetes mellitus, decreased urine output, low albumin, and bipedal edema. Tapos nabanggit niyo na po kanina yung it doesn't usually presents with stupor, generalized weakness, or absent Achilles reflex, and also altered mental status. And wala din pong recorded na blurring of vision. So yun nga po, yung dalawang differential diagnosis na andito is usually can be present nga po with the patient, hindi po siya yung about sa holistic na, about sa differentiating different diseases with encephalopathy. So, yun next slide.
Now for the next differential diagnosis, so for the first one, for the third one, it's acute ischemic stroke, and then the next is hypertensive encephalopathy. So for acute ischemic stroke, this was considered since meron pong altered mental status and poorly controlled yung hypertension and diabetes ng patient. However, wala kasing facial asymmetry and focal neurologic signs si patient, and wala ring headache, nausea, vomiting, and fainting, which that should be in the rule-in pero wala po kasi sa patient. For the rule out, bilateral kasi yung weakness, so it should be ruled out in the patient, and also may bipedal edema, and meron siyang metabolic derangements such as acidosis and uremia. Also, there are no fever or signs of infections and seizure. Now, for hypertensive encephalopathy, rule in din kasi poorly controlled yung hypertension and diabetes, and altered yung mental status. And ayun po, so wala rin siyang headache, seizures, nausea, vomiting, and focal neurologic signs kasi bilateral yung weakness niya and yung nangyari po sa kanya. And rule out din is mild kasi and not severely elevated yung blood pressure, kaya parang hindi rin maganda i-consider yung hypertensive encephalopathy. And also meron din naman siyang metabolic derangements such as acidosis and uremia, dyspnea, bilateral weakness, and bipedal edema na hindi naman nakikita sa hypertensive encephalopathy. Next slide, please.
Next slide, please. These were mentioned already earlier, but let's go over na lang din sa mga relevant diagnostic tests for this case. So, for the diagnostic tests, according to studies, uremic encephalopathy generally has a
Alvin,
variable and
yeah, before you proceed, let me ask you. So, example, you received this patient at the ER with decreased sensorium. So, you did a fast PE and a focused neuro exam, okay? And then you came up with a suspicion that this is a metabolic encephalopathy. Okay? So how will you approach this patient? Ano yung i-request mo muna?
if metabolic po yung suspected sa encephalopathy, possible po ba na ABG?
Yes, we will agree to a blood gas. What else? Kasi yung blood gas is arterial yan. And then the other one will be a venous extraction. So lahat-lahat ngayon. So what are you going to request? In order of priority.
ABG po muna and then electrolyte, CBC with electrolyte panel po.
So kasi ang electrolyte panel, marami yan, Aldrin, and it will be very expensive. So you have to choose what electrolytes do you want in order to practice health economics. Balik ka ngayon sa differential diagnosis natin, di ba? So, ang primary impression mo is uremic. So, you will have to include what in your blood test?
To add lang po with what Alvin said, Doc, I think we should include potassium and sodium, also
Louder,
bicarbonates
Therese.
po and chloride.
Louder, Therese,
Hello,
louder.
am I audible?
Louder. Okay, we can hear you. So, what do you want to request in order of priority?
So in order of priority po, we would want to get the patient status in terms of the levels of potassium and sodium. So this one we would,
So, your priority is potassium
and
and
also bicarbonate
sodium.
po,
What else?
bicarbonate.
Again, that will be included in your
Yes.
ABG. Okay? Nag-request na si Aldrin ng ABG. So, ikaw, in order of priority, sodium and potassium. Okay, hindi creatinine.
It's part po of the priority. So as Adrian mentioned earlier,
No, when you say priority, ano unang-unang mong i-request sa order sheet mo?
renal
Ang
function
impression mo
po,
is uremic.
creatinine.
So, dapat ang una mong order is creatinine. Ang differential
Yes,
mo
Doc.
will be, ano, uh, what's this? Hyponatremic and septic. Hypoglycemic and septic. So, ano na yung order mo? Next, creatinine, followed by sodium and potassium, followed by
Doc, choppy po kayo.
Hello? Hello, can you hear me?
Hello po, Doc. Yes po, narinig na po.
I've lost my internet. I'm using my cell phone now. Sige, we can proceed.
Moving forward to our laboratory test. So, na-mention na for the renal function, it is ang mini-measure is yung blood urea nitrogen and yung creatinine levels, which are found to be markedly elevated in cases of uremic encephalopathy. So this test may also indicate presence of renal failure or advanced renal dysfunction, as well as help monitor the adequacy of dialysis upon initiation. And then we can also ask for the liver function, which detects for hypoalbuminemia, which is common in ESRD cases then. And then for ABG, as mentioned earlier, it may also show presence of acidosis na nakikita rin sa ESRD. Next slide, please. Before that pala, mention ko lang din na yung uremic encephalopathy, generally variable and subtle yung presentation niya. So, there are no definite na confirmatory tests, which then causes delays in diagnosis. So, aside from measuring necessary evaluations, it is also important to rule out certain conditions that may mimic uremic encephalopathy, such as infections, hematoma, hypertensive encephalopathy, and such. And then, ayan, for serum electrolytes, na-mention earlier na this may help rule out possible electrolyte imbalances such as hypernatremia, hyponatremia, and hyperosmolar states. And can also help identify other possible metabolic causes of encephalopathy. So generally, derangements in these various electrolyte levels can contribute to encephalopathy. And then blood glucose can also be requested to rule out hyper or hypoglycemia as the cause of decreased sensorium. And then lastly, we can also ask for HbA1c. So this assesses for the patient's glycemic control, since it is mentioned that the patient is diabetic. Next slide, please.
So just to reiterate what Aldrin said, no, and to answer your question, Doc, the top three priority, we were to rank them. Of course, we would get the renal function, so to assess the overall status of the kidney. So that would be getting the creatinine and the bun, and then to rule out again what Aldrin said, the serum electrolytes should also be ordered, and then to check for metabolic acidosis, the ABG should be requested. So the next tests that I will be mentioning are to somehow check the overall status of the patient. So these ones naman are not the priority, but still important for a holistic treatment plan after the assessment. And then these can also be done to rule out some of the other causes of encephalopathies. So first we have your serum calcium, magnesium, phosphorus, and parathyroid hormone. So this would assess metabolic derangements that exacerbate encephalopathy. And for our patient po with end-stage renal failure, we expect and we saw earlier in the lab tests na meron na siyang secondary hyperparathyroidism, which is common again in CKD patients, no? So the patient manifested with increased phosphate, since the kidneys cannot filter out the phosphate in the patient's blood, and then compensated with hypocalcemia and increase in parathyroid hormone. Next, we have your serum lactic acid or your lactate. So this would assess for metabolic acidosis and tissue hypoperfusion as contributing factors to the encephalopathy. And then elevated levels of your lactic acid could indicate, again, hypoxia and contribute to the altered consciousness. Another thing that we can do is toxicology screens. So this rules out toxin-induced encephalopathy to detect drugs such as your cocaine, amphetamine, opioids, prescription drugs, alcohol, or toxins that can mimic or worsen CNS depression. So for this, hindi naman I think the most important thing is to check on the prescription drugs for the patient, since derangements can be obvious if the kidneys could not filter the drugs properly. And then we also have your C-reactive protein that can assess for infection or inflammation. So if the CRP is elevated, it could suggest systemic infection, which can trigger delirium or encephalopathy in CKD patients as well. So next slide. A question that we should answer is that if a lumbar puncture is needed. So for this case, or for encephalopathies or metabolic encephalopathies, it's really not that useful directly. However, if the patient does not improve after dialysis, it can be done to evaluate for CNS infection or inflammation. So it's basically for ruling out CNS infection or inflammatory causes when the encephalopathy persists despite the renal replacement therapy.
Okay, so moving on, in addition to the laboratory tests that we would be requesting, we could request for neuroimaging. So first we can do an MRI. So MRI, especially in neuremic patients with widespread brain involvement should be considered. So abnormalities can be found in the cortex, subcortical white matter, basal ganglia, and hippocampus, which may result in a variable clinical presentation. So doing an MRI findings, we can see that uremic encephalopathy may be grouped into three types. So namely, the first, cortical and subcortical involvement, the bilateral basal ganglia involvement, which is commonly seen in diabetic patients, and white matter involvement, which is a rare type of MRI finding. So for our case, we could consider the bilateral basal ganglia hyperintensities, which is sometimes or oftentimes called your lentiform fork sign. So these are hyperintensity surrounding your lentiform nucleus with a hypointense rim separating it from the internal and external capsule. So this represents cytotoxic and vasogenic edema due to your uremic toxins. So next slide, please. So along with the MRI, further evaluation of your uremic encephalopathy can be done using your electroencephalogram or your EEG. So as discussed earlier by John, that in your EEG, we can see the difference in your waveform. So a hallmark of your uremic encephalopathy is the diffuse slowing of background rhythm. So there is slowing of your EEG waves. So from your alpha, it can be directly proportional to the worsening of your renal function. So what can we expect in your EEG? So there is a loss of alpha frequency waves, overall slowing, and intermittent bursts of theta and delta waves, which are your slower waves, which is the slow background activity. So this can reflect also your global cortical dysfunction from the uremic toxins. And after the initiation of dialysis, your EEG changes to stabilize. It can stabilize but may not return to baseline. So there's some improvements may occur over several months. So your serial EEG can also be used to monitor the recovery of the patient after your dialysis.
Actually, we do not do serial EEG, Bea. We just monitor the patient, do neuro exam daily, so that we will know that the patient is improving. It's not a routine practice in the clinics that you do serial EEG. Okay, I would like to add that one of the pathognomonic signs in the EEG of uremic enceph is triphasic waves. Okay, though this is more common in hepatic encephalopathy. When you say triphasic wave, there is a spike and a wave and a spike. Okay, so yun yung makikita nyo aside from the slowing of the background activity. Okay? Sige, proceed.
Next slide. So for the initial management, we will do our ABC assessment. So for airway, so the patient has a GCS of 7 with partial pressure of carbon dioxide above 45. So airway management requires immediate intubation. And then for breathing, since the patient is tachypneic and has dyspnea, and the ABG is metabolic acidosis with hypoxemia, so mechanical ventilation must be done to support ventilation, correct hypercapnia, and improve oxygenation. And then for circulation, the mean arterial pressure is 90, so it means that it is adequate perfusion, so we just monitor. Next slide, please.
So for the pharmacologic treatment, so the main or the definitive treatment for the patient is hemodialysis. So the patient meets the guidelines, uremic encephalopathy, severe metabolic acidosis, life-threatening hyperkalemia, volume overload, and other electrolyte abnormalities such as hypocalcemia and hyperphosphatemia. So to do this, vascular access must be established. So since this is an emergency and urgent hemodialysis is needed, um, the vascular access would be your temporary central venous catheter. And then if ever the patient still needs long-term hemodialysis since she still has CKD, it could you could then transition to EVF, which would be used for long-term hemodialysis. And then another thing that must be done in hemodialysis is to assess adequacy of the dialysis. So essentially, you would see if how much of the toxins have been taken out already. So the adequacy target is actually 1.4 to deliver a target of 1.2. There's this formula called KT over V, which essentially measures the how adequate the dialysis is. And then another is to monitor for complications. So the vascular access, the temporary central venous catheter has high infection risk. So you have to make sure or you have to monitor for possible access related infections. You also have to monitor for possible hypotension. And then, of course, after hemodialysis, you should check if the electrolytes have been corrected. So you check for potassium,
Recording in
calcium,
progress.
phosphorus, and the acid-base status of the patient. And then you should also assess for adequate fluid removal and the hemodynamic stability of the patient. And see then if the uremic encephalopathy has already been resolved. And then for anemia, so the patient has high WBC. So it is important to rule out infection first since IV intravenous iron is contraindicated if the patient has infection. But blood transfusion can be considered if the patient is really hemodynamically unstable. Next slide, please.
Okay, for a while, everybody kindly open your camera as we are capturing the attendance. You are 446 and the present here in the synchronous is only 305. So the rest of you who are absent will have to explain to Dr. Lex Castillo. Okay? Please open your camera, everyone. Sige, Hawaiian, we are capturing your attendance. Yeah, we can continue the discussion.
So now we move to the pharmacological treatment of the patient's hypertension and type 2 diabetes. So as per the KDIGO guidelines, adults with hypertension and CKD is treated with a target SBP of less than or equal to 120 mmHg. While in comparison with AHA, the general target blood pressure for CKD patients with comorbidities is lenient, which is 130/80 mmHg. So although the admitting blood pressure of the patient is within the target, it is important to monitor and still provide pharmacologic treatment, knowing that the patient's usual blood pressure ranges from 160 to 180/100 mmHg and is reported to be non-compliant to her previous medication. So the first line therapeutic agent recommended by the KDIGO is ACE inhibitors or ARBs pre-dialysis. So although KDIGO does not specifically recommend it for patients with CKD under G5 category and A1 albuminuria, since the renoprotective benefit is most evident in A2 to A3 albuminuria and CKD G1 to G4, it is still considered the first line for BP control and cardiovascular protection, provided that the patient can tolerate it and is closely monitored for hyperkalemia and worsening kidney function. If the patient is already up for dialysis and the potassium levels are abnormal, the guidelines recommend the use of dihydropyridine CCBs for advanced CKD patients, and examples include the amlodipine, felodipine, and difedipine. However, the side effects of this medication should also be monitored since the CCBs can exacerbate the patient's peripheral edema. So additional agents to be added are diuretics. So as per the guidelines, elevated blood pressure in CKD is frequently attributable to fluid overload. Therefore, the use of diuretics, particularly loop diuretics, can be used in combination with the ACE or ARBs or the CCBs for lower GFR of less than 30 milliliters per minute. However, their benefit at this stage is largely symptomatic and adjunctive because diuretics do not alter the kidney disease progression once the GFR is severely reduced. In patients with G5 CKD complicated by pulmonary congestion and grade 3 bipedal edema, loop diuretics may still be employed at higher doses and sometimes in combination with diuretic for its synergistic effect. So next we move to the treatment of diabetes mellitus of the patient. So from the guidelines again, the recommended individualized HbA1c target ranges from 6.5% to 8%, but 7.5 to 8% is acceptable in advanced CKD, elderly, or high-risk patients. Since the patient was previously non-compliant with metformin, this drug should be discontinued. Moreover, metformin is contraindicated in advanced CKD with eGFR less than 300 ml per minute due to the high risk of lactic acidosis. So the most appropriate agents for this are insulin, DPP-4 inhibitors, GLP-1 receptor agonists, sulfonylureas, thiazolidinediones, and alpha-glucosidase inhibitors. And in choosing the appropriate agent, it is guided with patient preference, comorbidities, cost, and other characteristics. For the patient, insulin is the most suitable for advanced CKD since it does not rely on renal clearance. However, titration is necessary due to the reduced clearance and its risk of hypoglycemia. So next slide, please. So this slide just shows the schematic diagrams in choosing the suitable agent for the patients for DMT. Next slide, please.
So for the cardiovascular complications, KDIGO recommends that in adults age 50 or more than 50 years old with eGFR of more than 60, but not treated with chronic dialysis or kidney transplantation, it is recommended that statin or a ezetimibe combination must be done. So, yung primary goal kasi nito is to initiate cholesterol-lowering therapy in CKD patients since mga CKD patients have a very high baseline risk. So, the KD ko recommends statin therapy based on age and CKD stage rather than specific lipid threshold. So, since the patient has CKD stage 5, hypertension, diabetes mellitus, and left ventricular hypertrophy, which are all high-risk ASCVD enhancers, and since she is not yet on maintenance dialysis, so a statin plus ezetimibe combination at reduced doses is appropriate. So based on the SHARP trial, a lower dose regimen such as simvastatin of 20 mg per day plus ezetimibe of 10 mg per day can be considered. So next is since the patient has leukocytosis with neutrophilia, this may indicate infection or a stress response from uremia. So while dialysis may help reduce leukocytosis, if it is uremia-induced, it will not treat an underlying infection. So therefore, identifying potential sources of infection is essential. Empiric antibiotics should be started promptly if clinical suspicion is moderate or high and with doses adjusted for renal function while awaiting culture results. Next slide, please. So for the non-pharmacological treatment, first is the lifestyle and nutrition changes. So first, dietary sodium restriction. Sodium intake should be limited to 1.5 grams per day for patients aged 14 to 70 years old. So this would help control blood pressure and reduce the risk of volume overload. And then next is fluid restriction. So yung fluid restriction should be individualized based on urine output and interdialytic weight gain. So this is essential to prevent pulmonary congestion and edema, especially in patients preparing or undergoing dialysis. Next is protein intake. So a protein intake of 0.8 grams per kilogram per day is recommended for adults with CKD G3 to G5. So however, this must be individualized to prevent malnutrition, especially in elderly or frail patients. Next is potassium and phosphorus management. So, restriction of potassium is indicated, especially sufficient natin, which is hyperkalemic. So, foods to avoid include bananas, oranges, dried fruits, and coconut water. Phosphate restriction is also important to manage CKD mineral bone disorder and reduce vascular calcification risk. Next is caloric intake. So, adequate energy intake of 30 to 35 kilocalorie per kilogram per day should be ensured, tailored to age and activity level to prevent malnutrition and protein energy wasting. Next is diabetes-focused nutrition. Nutritional management of diabetes should emphasize carbohydrate control using low glycemic index foods, balanced meals with complex carbohydrates, high fiber intake, and strict portion control to optimize glycemic management. Then lastly, physical activity. So patients with hypertension and diabetes must be advised to undertake moderate intensity physical activity for a cumulative duration of at least 150 minutes per week or to a level na compatible with their cardiovascular and physical tolerance. Next slide, please.
So the following are the parameters that needs to be monitored for optimal patient improvement. First is the blood pressure. It may be checked daily to monitor and prevent further renal damage and minimizes cardiac strain associated with the LVH. For the weight and fluid status, daily weight measurements are performed to assess fluid balance and to evaluate the patient's other signs of fluid overload. This allows early detection and management of volume retention, which is essential for controlling the hypertension and protecting cardiac function. For the nutritional status, the patient's dietary intake, body mass index, and signs of malnutrition are regularly assessed. This is to ensure adequate protein and calorie intake while avoiding excessive kidney stress. Serum electrolytes, including sodium, potassium, calcium, phosphate, and bicarbonate, are monitored at least monthly or more frequently if abnormalities are detected. For the glucose and HbA1c, daily self-monitoring of blood glucose can be performed with HbA1c assessed every 3 months. Maintaining target glucose levels helps slow CKD progression and reduces the risk of microvascular and macrovascular complications. Lastly, for the lipid profile, fasting lipid panels, including total cholesterol, LDL, HDL, and triglycerides, are obtained every 3 to 6 months. Monitoring this informs interventions aimed at reducing cardiovascular risk and preserving renal function. Next slide, please.
So for patient education, the first one is disease understanding. So both the patient and the family should know about CKD progression, the nature of the disease, the need for dialysis, or the treatment plan for the patient. And the second one is medication literacy. So there should be clear explanation for each prescribed medication for the patient. And then you should emphasize the dangers of missed doses, double dosing, or self-adjusting the medications without medical supervision, as these can accelerate CKD progression. And then the third one is drug adherence and polypharmacy risks. So stress the importance of consistent medication intake for optimal disease control, and then address polypharmacy risks, including drug-to-drug interactions, by encouraging consultation with healthcare providers first before starting over-the-counter medicines or supplements. And then the patient or the caregiver should be updated or should have an updated medication lists that they can present during consultation should they consult other doctors then. And then for the fourth one is the adherence tools. So practical aids such as pill boxes organized by time of day, mobile phone medication alarms, and then caregiver or family reminder systems for intake of medication, as well as the simplified medication schedules with drug names and timing could be done. So these are the strategies to reduce medication errors and improve patient confidence in managing complex regimens while minimizing polypharmacy risks. Next slide, please.
As for the prognosis with uremic encephalopathy, it often shows clinical improvement with recovery taking several days to weeks once therapy is started. The condition tends to be more pronounced in acute kidney injury where there is rapid buildup of waste and toxins. But in this case, there is favorable prognosis for her neurological symptoms due to intact brainstem reflexes and symmetric motor findings. So her symptoms of stupor and confusion are likely reversible if dialysis will be given.
Next slide, please. However, delayed treatment can lead to serious complications or permanent neurologic sequelae, including seizure or coma. Prognosis may vary if there is possible basal ganglia involvement in the MRI, which is associated with worse outcomes, while other patterns such as yung cortical or diffuse white matter types have good prognosis.
So overall, the prognosis improves significantly with dialysis or renal transplantation in patients with end-stage renal disease. Poor prognosis is expected for patients with delayed treatment or those without treatment at all. Although some symptoms are reversible, changes in cognitive function may become permanent. Lastly, close monitoring is crucial since patient may develop severe complications during treatment, which can lead to death. So next slide. Here's our references po. That's the end of our report. Thank you for listening.
Okay. So, can you hear me? Can you hear me?
Yes po, Doc.
Okay, so how do you rate yourselves? How do you rate your performance? Sino group leader nyo? Who is the group leader? Si Aldrin? Hindi?
Ako po, Doc.
Okay, so how do you rate your group?
Ah, ano po, Doc? We did our best naman po in reporting. Nagkaroon lang po talaga ng siguro ng confusion with other parts. Pero ayun po, nakita ko naman po yung effort ng bawat isa sa ano po namin, sa different components ng report. Ayun.
Yeah, I agree. This is a very good presentation and I commend your pathophysiology. I like your pathophysiology, your concept map of the problem. Okay, we just have to improve on the localization as well as formulation of your differential diagnosis. Okay, so we can refine that as you go to our preceptorial classes when we handle actual patients. Okay, so overall, this is a very good presentation and congratulations to the group. I know you worked hard for this during the weekend. Okay, I'm just I'm not sure why there's no case for autonomic nervous system, but the lecture on this was also uploaded. Okay. So any question with not only approach to decreased level of consciousness, but also to autonomic nervous system. Na-view ninyo ba? Baka yung iba hindi pa nakikita yung lecture. Okay. In the autonomic nervous system, you have assignment. Okay, disorders of respiration and disorders of swallowing. And the reference is just Adams' Principles of Neurology. Okay. So very important in the discussion is that coma can be reversible. You just have to identify the cause because you have to act fast and manage the patient as soon as you were able to recognize the problem. Okay? Any question? None?
None na po, Doc.
None? Okay, so we will end a little early. Ay, hindi. 12 na pala. So you will have to eat lunch and attend to your afternoon classes. Okay? So good day and good luck. Good luck in your upcoming long exam. So I will get questions from Adams and the lecturer. Okay? Okay, thank you.
Thank you po.
Thank you, Doc.
Mhm.
Thank you, Doc.